Hi, my name's Connie Koklanis and you're watching the video Assessing the Range of Ocular Movements. In this video we'll be discussing how to go about assessing the ocular movements and in particular focusing on how to detect and record overactions and underactions of the extraocular muscles. So when assessing ocular movements, it's important that we do so utilizing the H pattern. The reason we do this is so that we're able to examine the muscle families. The family of muscles are those that form a muscle sequelae. So say for instance we had an underaction of the superior oblique or a palsy of the superior oblique, we would be interested in looking at the yoke muscle, the ipsilateral antagonist and the contralateral antagonist. And the H pattern allows us to do this in a systematic approach. So below here we have an ocular motility simulator from the web available at the website on this page, and I can move these eyes around to give you a demonstration of the H pattern. So with the H pattern we usually commence with the horizontal gaze. So if we look over to right gaze, we would be assessing two yoke muscles here, the right lateral rectus and the left medial rectus. And we then want to look at the ipsilateral antagonist of these muscles, so we'll go over to left gaze and assess the ipsilateral antagonist of those muscles that we looked at in the first instance. Now, for vertical extraocular muscles, we need to move over into right or left gaze, and I'll start off with right gaze, and then we move, say for instance, into up gaze, and here we'll have a look at the two vertical muscles, the superior rectus of the right eye and the inferior oblique of the left, and immediately after this we will look at the ipsilateral antagonist of each of these muscles. Okay, so say one of those particular muscles was palsied, what we've effectively done is had a look at that muscle family which would form the muscle sequelae. So once we finish one particular gaze, we'll move over, say for instance, in this instance, to left gaze. And again, moving up, having a look at that superior rectus and inferior oblique, and then we'll move down and have a look at the inferior rectus and superior oblique. And that in effect forms the H pattern. Now we can also look at elevation and depression, or up gaze and down gaze. Again, remember that up gaze and down gaze, we don't actually isolate the extraocular muscles, but what we will be looking for here is when we look up in up gaze and down gaze, we will be looking for AV patterns. So when assessing ocular movements, we're examining versions and determining if there are any underactions or overactions of the extraocular muscles. Remember that when you're assessing extraocular muscles, each of these extraocular muscles is supplied by a cranial nerve, and thereby if for instance we have a limitation of the superior oblique, we will need to determine whether this is due to a fourth nerve palsy. If you notice an underaction or overaction, you also need to perform a covered test in the position of gaze where you note this over or underaction to verify the observation. Also, you need to observe if there's any downshoots, upshoots, downdrifts or updrifts. This is a movement that you'll see on horizontal gaze, such that you'll see as you're moving the eyes into horizontal gaze, you'll see a vertical movement. The eyes will shoot up or down, or drift up or down. And as the word suggests, the difference between these two phenomena are that one is a gradual drift up, the other is a fairly abrupt shoot up, as an example. Okay, where you see limitations, you should also examine ductions. Now, there is a section of this inquiry dedicated to ductions, but it is important to mention ductions here because when you're assessing ocular movements, you should proceed to assess ductions at each instant that you see an underaction. So if, for instance, you're seeing right AB duction limited, you should cover the left eye and see whether you get any additional movement during testing. Now, additional movement or an increase or improved movement of the eye or abduction in this example would indicate that we have most likely a neurogenic palsy. However, if the movement was unable or abduction was not improved with ductions, then it would indicate that we perhaps have a mechanical restriction. Okay, and finally, don't forget to assess up gaze and down gaze for your AV patterns. Just a couple more points. Whilst you're assessing ocular movements, it's important that you observe the corneal reflections. The corneal reflections will guide you as to whether there may be overactions or underactions, as you have the relative positions of the corneal reflections to compare. Now, it's important that when you're testing a patient with a torch, that you can actually observe the corneal reflections of the patient. So you need to hold the torch in a position such that you will see the corneal reflection from the two eyes. If you have a young child or an infant, at times it can be quite difficult to engage them with a torch as a target. So in these instances, you may need to abandon the use of the torch and move to toys. But certainly when you have adults or a cooperative child, you should be performing ocular movements with a corneal reflection, and of course subsequently the cover test where you see a asymmetry. Finally, always remember to take off the glasses during testing of ocular movements. The glasses obstruct your view and the patient's view during testing, and because it's not necessary to utilize an accommodative target during ocular movements, it's okay if the patient is blurry during the testing. What you're seeking them to do is to follow the target and for you to look at the range of movement upon following that target. During ocular movements, you should also observe the globe and lids and document any changes that you observe. Also record any associated signs. So if a patient, for instance, indicates that they have pain in right gaze, you should record that. If we have a look at the image to the right, we can see here that there's some limitation of eye movements, but we can also see that the right palpable fissure has narrowed, and we can see that the globe has retracted. So these are observations that we should also record when we're assessing ocular movements. A couple more things to note or observe whilst assessing ocular movements. You can have a look at the way in which a movement seizes. So if you have an underaction, you can observe the way in which that particular eye stops moving in a particular direction. And generally we do this to get a feeling of whether it's abrupt, which is tending to indicate a mechanical restriction, or whether the movement ceases more gradually, which can lean you towards being neurogenic in nature. Also, observe whether the limitation you observe is such that it affects a large range of positions rather than a specific position. Now, when a limitation affects a range of positions, it's likely that you have a mechanical restriction as opposed to a neurogenic. To the right, we have a patient who is looking into up gaze. And if we look at prime position, they're fixing with the left eye, and what we can see is that the right eye is not elevating or is limited in its elevation. In dextro elevation, we have the same problem where the right eye is limited in its elevation. And then again, if we look into levo elevation, we have the right eye limited in elevation. So here we have an example of a patient who has a limitation across a range of positions. So direct elevation, dextro elevation, and levo elevation. This is hinting, or this is an indication that there is likely to be a mechanical restriction here. If it were a neurogenic palsy, on the other hand, usually what you would see is one position of gaze being affected, say for instance levo elevation, but you would not see it also in dextro elevation and perhaps not even in direct elevation. So with ocular movements, we will grade any underactions or overactions that we observe, and we utilize a 9-point scale. 0 indicates there is no overaction or underaction of the specific extraocular muscle, and then an underaction is documented with a minus value, and an overaction is documented as a plus value. The higher the value, the greater the underaction. So a -1 is the least amount of underaction versus a -4, greatest amount of underaction. Some orthoptists will grade in halves, so you may see notes 1.5 And it's also worth noting that as you'll see in the subsequent slides, that you can actually have a underaction or overaction of greater than 4. Some orthoptists again will actually grade above 4 and say -5, -6, and others will just write greater than 4 in those particular instances. Okay, let's have a look at this. So let's start off with the horizontal muscles, and then we'll move on to vertical muscles. And we'll start off with looking at underactions of horizontal muscles. To begin with, what do we expect to see in terms of a normal horizontal movement? And if we look at von Norden and Campus's images here, what we have is that when we're looking at abduction, we want that corneal limbus to just be touching the outer canthus. So you're not seeing sclera when you have full range of movement. If we move over to adduction, we can see here that approximately about a third of the cornea is in line with the punctum. So we will use this as a reference point and then grade the limitation accordingly. Now, -1 is 75% of normal movement, and here we usually just begin to see sclera. A -2 is 50% of normal movement, -3, 25% of normal movement, and a -4 is an eye that makes it to midline but can't move beyond midline. And this is where we then can grade greater than 4 if the eye doesn't even get to midline. Let's have a look at a few examples. Here we have a couple of patients with abduction deficits. Now for the top image, we have a right lateral rectus palsy, and what we see is a deficit or a limitation in right abduction. But the eye does come to midline, it just does not go beyond midline. If we look at the image below, this time we have a left abduction deficit, and if we look over to lavoversion, what we can see is that the eye doesn't even make it to midline. Okay, so this is a difference between an eye that's a -4 or greater than -4. One more example. These are images of a patient preoperatively and postoperatively. And the top image is pre-op, and what we can see here is that the eye, or the right eye, is making it to midline but cannot fully abduct. And then post-operatively, we have an increase in the movement, and we can see that the patient has now moved beyond midline. Now let's look at the overactions of the horizontal muscles. These are a little bit more difficult to grade, but what we will do is grade according to the amount of cornea covered by the canthus. So we use again the same reference points that we talked about earlier. And what we can also indicate is that when you're looking at an eye that is of +4, you're looking at half the cornea buried in the canthus. Moving on now to vertical muscle underactions and overactions, we have a couple of other elements we can look at in determining whether there's an overaction or an underaction of the extraocular muscles. So we'll of course look at the relative positions of the eyes, but now we can also look at the height of the limbus of each eye and the position of the eyes relative to the palpable fissures. So if we have a look at the image here to the right, we can see that the corneal limbus of the left eye is higher. We can see what looks like there is a left hyperdeviation, and we can see more sclera between the limbus and the lower lid on the left eye as compared to the right eye. So we have a couple of more reference points we can utilize in looking at vertical deviations. So with grading of underactions, it's the same as how we grade the horizontal muscles, looking at a percentage of normal movement. If we have a look at the example here to the right, this patient is looking into dextral elevation and fixing with their left eye. And what we can see is that this eye is not elevating. It's come to midline or just under midline and cannot actually elevate. And so here we can see in that diagnostic position that superior rectus is not elevating the eye. Let's have a look at a couple of examples using a left inferior oblique overaction and have a look at the various gradings of these underactions. Okay, these patients will be in dextral elevation. So this one that we see here is looking into dextral elevation, and here we can see that the left eye is slightly lower than the right eye, and we have a -1 underaction. In this instance, we can see that the underaction of that left inferior oblique is slightly more, the height is slightly more as well, so we have a greater left hypo deviation, and here we have a -2. In this instance, the eye has just started to elevate and move beyond midline, and we have a -3. And in this instance, we can see that the patient has not moved beyond midline, and we have a -4. Vertical overactions are a little bit more difficult to assess as compared to underactions, as the guidelines are less specific. Now, in general, if you notice an underaction, then the contralateral synergist will be recorded to have an overaction of the same amount. Now, you need to obviously perform a cover test in that position and confirm that you think that the underaction is equal to the overaction, but often this may be the case. Okay, for oblique muscles, in particular the inferior oblique, we have a couple of guidelines that assist us in documenting whether it's a +1, 2, 3, or 4. So a +1 is a deviation where the vertical deviation is only present in the field of action. So if we have a look at the example here, if we look at the girl, she's in dextral elevation. In order to call it a +1, what we would see is that if we had all 9 positions, that this vertical deviation was only present in dextral elevation and in no other position of gaze. Now, a +2 indicates that we also see the vertical deviation in horizontal gaze. In this particular example, we would see it in dextroversion, and what we can see is that indeed there is a vertical deviation in dextroversion and a vertical deviation in dextro elevation. Now, the difference between the +2 and 3 is whether you believe that whether you find that the vertical deviation in dextroversion is small or large in nature. And finally, a +4 is where we also have the eye diverging out as we move into the field of action of the oblique muscle. So what we would see is that in that image in dextral elevation, we would actually see that the eye was not only vertically up, but we'd actually start to see it diverge out. Let's have a look at a few examples of a right inferior oblique overaction. So these patients will be in dextro elevation and they're fixing with the left eye. In this image, we can see only a slight right hyper deviation, and this would be classified as a +1. Now, if you're struggling to see that upon observation, in clinic you would have corneal reflections which would show you that there's subasymmetry, and you would perform a cover test to confirm the overaction that you're observing. So in this instance, we would cover the left eye and we would see that right eye come down to take up fixation, confirming again that we're having that overaction. So in this image, you can now start to see more obviously the right hyper deviation, and here we have a +2. In this instance, the hyperdeviation is increasing again, we have a +3. And in the final image, we can actually see that not only do we have this hyperdeviation, but the eye is starting to diverge out. And here we have a +4. Now, given the descriptions I've given you of the overactions and underactions, we would also have, for the last 3 images, the +2, 3, and 4, we would also see that vertical deviation present in horizontal gaze. Finally, we need to assess the patient for AV patterns. So once you've completed the H pattern, we'll look at the AV patterns, and in this instance what we're interested in is the horizontal deviation. So even if your patient has a vertical and horizontal deviation, we'll measure both in up gaze and down gaze, but in order to classify the patient as having an A or V pattern, all we're simply interested in is the change in the horizontal component of that deviation. So if we have a look at the patient here, we can see that in primary position, there is a slight right exo deviation or exotropia. And then when we move into up gaze, we can see that there's an increase in that exotropia. And then when we move into down gaze, we have a decrease in the exo deviation. And so what we have here is a V pattern. Now, because V patterns are physiological, we need at least 15 prism diopters of difference between up gaze and down gaze to classify the patient as having a V pattern. And because A patterns are not physiological, we only need 10 prism diopters of difference. There's a video dedicated to AV patterns, so we'll talk about these more specifically when we get to this point in the lecture series. Okay, so how do we record ocular movements? Now, before I proceed to discussing this, I need to bring your attention to the fact that there are two methods of assessing and thereby recording overactions and underactions of the extraocular muscles, the British method and the American method. Now, the British method, in order for an extraocular muscle to be classified as overacting or underacting, there needs to be a change in the size of the deviation from primary position to the affected position of gaze. So what this means is that if we look at the girl here, we see that it appears that in dextral elevation we have a left inferior oblique overaction. So we have a left hyperdeviation and we have what appears to be a left inferior oblique overaction. Now, in order for it to be recorded as a left inferior oblique overaction, the British method requires that there has been an increase in the hyperdeviation from primary position to this position of gaze. The American method does not require this. Okay. For this method, it is purely upon observation that if the eye appears to be overacting, or the extraocular muscle, in this instance inferior oblique, appears to be overacting, it would be recorded as such regardless of whether there was a change in the size of the deviation between primary position and dextral elevation. Let's have a look at the same patient in 9 positions of gaze. We'll only look specifically at primary position and dextral elevation, but we can see here that in primary position there is a slight left hyperdeviation, and when we have a look at her in dextral elevation, we can see that there's been an increase in that hyperdeviation. Now, we can measure the deviation in those two positions and have further confirmation that there's been an increase in that vertical deviation between those two positions. So in this instance, this would be considered a left inferior oblique overaction utilising the British method, and it would also be considered a left inferior oblique overaction utilising the American method. Now, there are two ways of recording ocular movements, the descriptive and graphic method. The descriptive method is just that, you describe what you see. So here we have 3 examples of the descriptive method. First one indicates no apparent defect, so there was full extent of eye movements and all the extraocular muscles seem to be moving normally and have full range of movement. The second one, we have a right inferior oblique overaction and a right superior oblique underaction. And in the third instance, we have a limitation of elevation in adduction, so more of a description of what is occurring there. Okay, again, don't forget to record any lid changes or pain on movement, etc. that might be occurring or you might notice during ocular movement testing. For the graphic method, we utilise a diagram to illustrate the ocular movement assessment. And so what we have here is each position representing a specific extraocular muscle. So here we've got the superior rectus underacting. Here we have the lateral rectus of the right eye fully abducting. And here we have the inferior rectus overacting. Okay. The arrows in the centre of the eyes indicate AV patterns, and in this instance we have a V pattern. The arrows here indicate that we have a updrift of the eye, and it's the soft arrow that indicates it's an updrift. If it's a hard angle, it is a upshoot. Okay. We can also see values here, 50 diopters, 30 diopters, 15 diopters. Where we see values, it's indicating is that a prism cover test has been performed, and so we also have the prism cover test for up gaze primary position, down gaze, and we also have the right gaze and left gaze measurements. Okay, what we don't have here in this particular example is shading. Okay. If you go to the BIOS document, which is on LMS, you will be able to see more examples and see how shading is utilised in those examples. So now if we have a look back at Miss Jones's case notes, we can have a look at the recording of the ocular movements. And here we have what's been recorded. So the descriptive method has been utilised. We can see that there's a right inferior oblique overaction that's slightly greater than the right superior oblique underaction. The orthoptist had made comment on the fact that the obliques, or the left oblique, so the left inferior oblique and superior oblique, seem okay. Now this does happen at times, and in this instance the orthoptist is trying to rule out the possibility of a bilateral issue, and so has documented that she or he has looked for it and has indicated there is no left oblique issues. It's also indicated that there's a moderate V pattern. So in summary, you should assess ocular movements using the H pattern. And whenever you think you have observed an underaction or overaction, you should perform a cover test in this position to verify your observations. You should perform ductions whenever you think you see a limitation. And again, if there is an increase in the movement, usually this is indicating that we have a neurogenic palsy, as compared to if we see no improvement in movement, it's likely that it's a mechanical restriction. Okay, look for any associated signs, look at the lids, look at the globe, note any pain, and record those associated signs. And you can record either in the descriptive or graphic method, and in Australia this is fairly variable as to what method is being utilised. Okay, that brings us to the conclusion of this video. Thank you for listening.